Okay, thank you.
Dear participants, dear friends, our conference, the 6th International Scientific Practical Virtual Conference in Modern Medicine and Health is beginning. Many universities take participation in our conference. For the first time, I want just invite for speak here. I would like to invite from the Tepecik Medical University, Melis Hanım. Please, Melis Hanım.
Okay. Hello to all dear colleagues. Firstly, I want to thank the scientific committee, and I'm very proud of being a member of editorial board. I'm now sharing my presentation. Okay, you see. I will present today to you adalimumab usage in a case with psoriasis and Duchenne muscular dystrophy. Psoriasis is a sharply demarcated chronic inflammatory skin disease and characterized by erythematous plaques.
Your PPT not visible. We cannot see your sharing.
I'm sharing now.
Yes, we see one of your folder on your screen.
Can you see now, or my screen?
No, just close the window, which
No.
as we see.
I'm trying again.
Can
1 minute, please. I will go out and then I will try again, okay?
okay, no problem. Just you can explain.
I leave now and then we'll connect again.
Okay. Yes, next speaker, 1 minute. Eka, you can continue.
Yes, Mr. Nami, I just wanted to welcome the audience, if possible, please. So can you hear my voice?
Yes.
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 Okay, thank you very much. Dear ladies and gentlemen, dear professors, honorable members of the Zoom audience. First of all, I would like to kindly welcome and greet each and every one of you and wish you a very fruitful, productive conference day ahead. I'm Ekaterina Lomya, PhD in political science from Tbilisi, Georgia. Today, I represent the Teaching University Millennium Department of Internationalization, Career Development, and Public Relations. More concretely, I'm a Research and Internationalization Coordinator at the mentioned university. We are extremely proud that our university is one of the invited organizers to this amazing conference. I would also like to take the advantage and warmly greet the professors of our university as well, who are participating in this conference. I wish success to all of them. As for the conference itself, of course, my huge gratitude goes to the organizers of this conference. I thank Mr. Nami Gisadze, without whom the conference could not have taken place, actually. Thanks to the International Center for Research and Education Training Center, Al-Farabi Kazakh National University, Faculty of Medicine and Healthcare, Higher School of Medicine, the Southern Caucasus International Academy of Modern Sciences, UK, and International Academy of Medical and Social Sciences, UK. In a few words, I would also like to highlight the topic of the conference as well, the 6th International Scientific Practical Virtual Conference in Modern Health, Prognosis, Achievements and Challenges. Of course, the topic is quite diverse and let's say it refers to the most important and necessary issues and problems that the medical field is facing today, especially following the outbreak of the coronavirus pandemic that globally changed the world. As a consequence of this, we see that medical approaches are also gradually changing in today's world of globalization. So I deeply hope this conference will reveal new findings in the medical field and hugely contribute to the medical society. Thank you very much. That's what I wanted to say, actually. Thank you.
Okay.
And now, the next presenter.
Ben bağlandım bu arada.
Sorry?
Okay.
I connected.
Okay, thank you very much. Thank you very much. The floor is
Thank
yours.
you.
We're waiting for you. Thank you.
Yes, Melis Hanım, you can continue. Melis Hanım.
Okay. Can you see my screen?
Yes, we see, but just
Actually, we can see the screen, but not the presentation itself. I think there is a problem again.
presentation first. After that, you share your screen.
Do you see my presentation?
No. Can you move down the page? Sunumlar. Maybe behind the sunumlar we can see.
Stop share. I stopped share. Share screen.
Yes.
I opened my presentation. Do you see now?
No. Just what this file, bu file var sunumda. Onu aşağı indirin. Ondan sonra belki onun arkasında da.
Sunumlar.
Evet.
Sunumlar nerede? Şimdi share screen yapıyorum değil mi?
Evet.
Tamam. Her zaman yaptığım şey ama.
Olsun, kendi sözlerinizle söyleyin, yani problem
Yani
yok.
o olabilir. Ama şaşırdım yani. Bir daha deniyorum.
Mr. Isadze, maybe we can, okay, we could see your presentation a few seconds ago.
Okay.
I think it was a presentation, or
Yes.
maybe we can move to another participant and later on.
Do you see now?
No.
Hmm. No, do you see?
No, actually, it's the same.
Okay, I
But we
present
see it.
verbally. Adalimumab usage in a case with psoriasis and Duchenne muscular dystrophy. Psoriasis is a sharply demarcated chronic inflammatory skin disease and characterized by erythematous plaques. Its most important factors in the pathogenesis are genetic, environmental factors, and ethnicity. In treatment, we use different biological agents, and one of them is adalimumab. I want to present a case with psoriasis and Duchenne muscular dystrophy treated with adalimumab. Our case was a 23 years old man, male patient with psoriasis and Duchenne muscular dystrophy. He had his disease for 12 years and didn't smoke or drink alcohol. We determined his psoriasis area and severity index as 10.2. Earlier, he used methotrexate but developed resistance to this treatment. And we started adalimumab for our patient after receiving the options of the physical and rehabilitation clinic of our hospital. Actually, you don't see the photos of our case. At the sixth week control, we achieved PASI, psoriasis area severity index, 90 response. We didn't experience any drug-related side effects. Our patient is now in his 6th month in adalimumab treatment, and PASI 90 response is going on. In the treatment earlier, PASI 75 response, but nowadays PASI 90 and even PASI 100 response are targeted. Adalimumab is a tumor necrosis factor alpha inhibitor and recombinant fully human monoclonal antibody. Rarely, it can cause severe adverse effects. I say nowadays some adverse effects: tuberculosis, lupus-like syndrome, demyelinating diseases, congestive heart failure, panstopenia, rising of transaminases, palmoplantar pustulosis, leukemia reactions, bullous eruptions, alopecia, hepatotoxicity, and malignancies. Duchenne muscular dystrophy is progressing with progressive degeneration and atrophy in the muscles, and is the most common inherited illness in all muscle diseases. Especially it occurs in male cases. Duchenne muscular dystrophy is a rare disease, and its coexistence with psoriasis is a very rare status. No similar case report was found in the literature. We wanted to present both this rare status and psoriasis progression under adalimumab treatment. I thank you very much for your audience.
Melis Hanım teşekkürler. Thank you, Melis Hanım.
Thank you.
Ben de çok teşekkür ederim.
Dear Eka, you can invite speaker.
Yeah, thank you very much to the presenter. And right now we have Georgian presenter, Damas Kurashvili. Insulin therapy in patients with breast cancer. Mr. Kurashvili, if he's here.
Yes, he is here.
He also is a professor at our university, and we are proud of it. Can you hear us, Mr. Kurashvili? We can't hear your voice, unfortunately. I think there's a technical problem again. Mrs. Shelestova, can you hear us? Okay, we can see the presentation, but we can't hear you, sorry.
Georgi unmute.
Kargia?
Okay, yes, it's amazing.
Yes,
Thank you very
okay.
much. Thank you.
Okay, thank you. All the best, dear friends. Peace and progress. Hello, my dear colleague, Mr. Namik. Ekaterina, Queen's name. Hello.
Hello, hello.
Hello. Insulin therapy in patients with breast cancer. You know, the big problem, diabetes plus cancer. Dangerous liaisons, diabetes and cancer, well known, almost 90 years old, but in practical life, not active knowledge. Type 2 diabetes and cancer unite obesity, lack of physical activity, hyperinsulinemia, inflammation, poor diet, smoking. Remember, diabetes is a chronic disease associated with abnormally high levels of glucose in blood and chronic glucotoxicity. Global numbers of people with diabetes growing dramatically. Now we have a pandemic situation on the world. 1 year ago, 537 million people with diabetes. At 2030, 643 million, and we are waiting to 2045, almost 80 million people with diabetes. And with non-diagnosis, unknown diagnosis, double higher. Related deaths in diabetes, 6.7 million people died of diabetes globally, 2.5 million plus during next 2 years. Every 5 seconds, one person with diabetes died. It's what we know, diabetes kills more people than AIDS, HIV, malaria, tuberculosis taken together. It's almost secret data, you know, 1.1 million AIDS, HIV, 200,000 malaria. By the way, malaria is the #1 killer on the world during civilization, and tuberculosis, 1.8 million people. Number of deaths by cause, world 2017. #1, cardiovascular diseases. #2, cancer. And behind of 2 killers is diabetes mellitus, #9 on the world. The leading cause of death globally, cardiovascular diseases, respiratory system, and diabetes is #1. And the countries like Georgia is the cardiovascular disease #1, respiratory system #4. Now diabetes is #6, and stomach cancer is #9. cancer, diabetes, and mortality. Cancer mortality is also increased in patients with diabetes mellitus compared to non-diabetic population. This association has been reported for both short-term and long-term mortality. In addition of hyperglycemia and hyperinsulinemia that favor cancer progress and aggressiveness. Many factors can contribute to the increased cancer-related mortality in diabetes mellitus. And diabetes mellitus is almost unknown on the clinic of cancer because they don't have any time. You know, it's very, very dangerous situation for patients with diabetes. Patients with both cancer and diabetes often undergo less aggressive anti-cancer treatments as they also have cardiac, renal, and neuropathic diabetes complications, which may in turn concur to the worst therapeutic response. Type 2 diabetes mellitus is characterized by insulin resistance, poor glucose utilization by peripheral tissues such as skeletal muscle, and compensatory increase in circulation ensures levels hyperinsulinemia and hyperglycemia. The hyperinsulinemia increases insulin-like growth hormone factor, IGF, which is correlated and increased risk of breast cancer. By 2040, compared to 2020, incidence of breast cancer increased by 47%. Very high. Breast cancer is the most frequent cancer among women. 2.1 million women each year. It also causes the greatest number of cancer-related deaths among women. In 2018, it is estimated that 627,000 women died from breast cancer. That is approximately 15% of all cancer deaths among women. Women with type 2 diabetes have a slightly but significantly higher developing breast cancer than women with no diabetes. The elevated risk was apparent among postmenopausal women, but not among premenopausal women. Diabetes is associated with an increase in cancer mortality. Similar to hyperglycemia, higher fasting serum insulin or C-peptide, a marker of insulin production, levels are also associated with poor prognosis in breast cancer patients. Increase in serum C-peptide was associated with 35% increase in death due to breast cancer and 31% increase in overall risk of death. Hormones, some hormones are killers. Look, medications, the glucocorticoid used in chemotherapy treat nausea and inflammation, often cause hyperglycemia or increase in blood sugar levels. A result of one study showed that out of all subjects, 97%, 9.7 developed diabetes average follow-up of 5.8 years, 2 years after diagnosis. The risk of diabetes among breast cancer survivors grew to 7% compared with women without cancer. Research has shown that stable hyperglycemia and elevated levels of insulin, IGF-1, are associated with malignancy progression. It is thought that type 2 diabetes mellitus is associated with high risk of breast, liver, lung, endometrial cancer, while type 1 diabetes is associated with cervical, neoplasm, and stomach cancer rise. Diabetes cancer. Multiple studies suggest a correlation between diabetes and poor prognosis. However, a cause of effect relationship is not clear. Nevertheless, available data and clinical experience provide strong rationale for bringing endocrinologists and the oncologists into the same room and including diabetes management as part of the breast cancer treatment program. We are first team who had a one-room endocrinologist, myself and my partner oncologist in Georgia. First time we have a one room and one mission. Diabetes and cancer, what is it? Main program. It should also be considered that diabetes is undiagnosed in a large number of patients. Sometimes hyperglycemia is newly detected both when already present before cancer diagnosis and also when caused or aggravated by the tumor. Diabetes mellitus, cancer, other incidental common risk factors, for example, sex, age over 40 years, obesity, tobacco use, diet rich of fats, saturated fats, trans fats, red meat and processed meat, alcohol in large amounts, low quality alcohol is very important also, insufficient use of fruit, vegetables, and fiber, low physical activity, stress, and or depression. Depression also growing diseases, radiation exposure, history of cancer, breast, uterus, cervix, ovary, hormones, estrogens in hormone replacement therapy, birth control pills, genetic predisposition, certain conditions that are inherited. As diabetes mellitus, cancer, and other NCDs share common risk factors, we have to first identify risk factors, second, eliminate these risk factors. All diabetic patients, independent of their age and sex, should be regularly screened for cancer. Besides, actions should be taken to eliminate such common risk factors as obesity, passive lifestyle, unhealthy diet, tobacco use, and others. Some causes of hyperglycemia and oncology patients, enteral and parenteral feeding, concomitant infection, steroid administration, stress caused by severe diseases, hyperglycemia can lead to dehydration, diabetic ketoacidosis, hyperglycemic hyperosmolar condition, coma, and death. And very important, poor glycemic control leads to aggravation of both conditions and can cause life-threatening complications. Treatment of diabetes in oncology is complex and requires high responsibility, deep knowledge, and the skills to initiate glucose-lowering therapy and titrate doses of anti-diabetic drugs these patients among oral hypoglycemic agents, short-acting preparations, repaglinide, and not sulfonylureas with 24-hour activation period are recommended. Metformin, a widely used anti-diabetic medications, was shown to improve the breast cancer treatment response rate in type 2 diabetic patients. And insulin is a drug of choice and the first-line treatment in oncologic patients with diabetes. The use of last-generation insulin preparations in oncologic patients, good diabetes control promise and avoid a large number of problems associated with diabetes management in this population. And very important, insulin January 2022 marked the 100 years anniversary of treating and saving person's life. They started in USA 100 years ago. Insulin therapy is characterized by high efficiency, fast onset of action, flexible insulin regimen. Insulin therapy is often used in oncologic patients with type 2 diabetes who are receiving chemotherapy, corticosteroid therapy, painkillers. There are 3 companies all the world producing high quality insulins: Eli Lilly, Novo Nordisk, and Pfizer. Short-acting insulin analogs, Aspart, Norapid, Lispro, are used for the management of postprandial hyperglycemia. They are injected before each main meal. Basal-octane insulin analogs, Glargine, Levemir, are used to manage fasting hyperglycemia. They are not bound to meals. Management of combined cancer diabetes condition is complex, as a number of specific problems should be considered. Some of them are: what glycemic target to set, what therapy is a priority, what should be done in patients on corticosteroid therapy and during artificial nutrition, what is drug interaction, how to manage chronic diabetes complications, how to manage diabetes at the end of life. Very important to filling this one. Oncologists without endocrinologists cannot do this. List below patients' problems still more complicate the situation. Resistance of initiating insulin therapy, problems associated with proper eating during insulin therapy, need for regular self-blood glucose monitoring, SBGM, very difficult to use. We need other specialists, professionals. Fear of hyperglycemia, necessity to attend diabetes education classes. Insulin therapy, priority of insulin deglutec used in cancer patients with diabetes. 1 injection a day can be injected anytime. If a patient's unable forgets to inject insulin, he or she can do it many times as soon as remembers then to follow recommended insulin regimen. Flexible dosing, minimal 8 hours, maximal dose 40 hours with stable effect of action. No add-up effect. Insulin in depot does not enhance the effect of dose injection. High efficacy, reduced risk of hypoglycemia of any type, light, moderate, severe, night hypoglycemia. Timing of flexible insulin administration. The map is here. For example, for our mission from 8 to 12 and from 36 to 40 hours between insulin administration. It's a fantastic #1 possibility to filling it diabetic patients in insulin therapy. Hyperglycemia and diabetes mellitus management, therefore, are crucial to avoid the damaging effects of combined cancer and diabetes condition that will negatively affect quality of life and overall survival in these patients. National Center for Diabetes Research, myself and my colleagues from Institute of Clinical and Oncology are carrying out a study. The aim of this study is to achieve long and stable normal or near to normal glycemia using new generation ultra long-acting insulin analog degludec and study its effect on outcomes in patients with combined cancer diabetes condition type 1, type 2, and steroid-induced diabetes mellitus who are receiving chemotherapy. Totally 180 women with breast cancer and diabetes mellitus were enrolled in this study. All women were receiving chemotherapy. All women with breast cancer had either already diagnosed type 1 diabetes mellitus, already diagnosed type 2 diabetes mellitus on insulin therapy, and steroid-induced diabetes mellitus, mean age 58 years, BMI 31, hemoglobin A1C 9.8, ketonuria and glucosuria were registered in 90% of patients. Admission, type 2 diabetes mellitus patients, we are on combination therapy, oral hypoglycemic agents plus basal insulin. Type 1 diabetes mellitus patients were receiving short-acting and basal insulin. In all the patients, basal insulin was replaced by ultra-long-acting insulin analog degludec. In steroid-induced diabetes treatment was initiated with ultra-long-acting insulin analog degludec. Insulin doses were selected and titrated individually. It's very easy, by the way, comparison with other insulins. Short time titration without any risk of hypoglycemia. 1 month post-degludec initiation, positive dynamics of hemoglobin A1C, glycemia normalization, and minimal glucose variability were observed in all the patients. Improved general condition is on the face. 2 month post-degludec initiation, both objective and subjective indices were improved in all our patients. Hemoglobin A1C, remember it was 9.4 and now 7.3. Improved general condition and quality of life, more energy, readiness to fight for life and continue chemotherapy. It's very important because after hypoglycemic episodes, most patients are not ready to continue chemotherapy. Patients treated with degludec reported practically no hypoglycemia episodes, absent of hypoglycemia, encouraged them to continue chemotherapy. Based on our results, we may suggest that in oncologic patients, ultra-long-acting insulin analog significantly more effectively normalized glycemia control. The basal and short-acting insulin preparations used previously, stable good glycemia profile leads to improvements in general conditions and quality of life that positively influences the recovery process and improves cancer prognosis in these patients. Thank you to my colleagues, Maya Nishnyanidze, endocrinologist in our center, and Professor Gia Nebsadze, director of Institute and clinical oncologist, and my right hand, Elena Shelestova from Georgia. Thank you, Mr. Namik and Mrs. Ekaterina. Thank you. Thank you.
Thank you very much. Thank you very much, Professor Kurashvili. We are very proud that you are our professor. Thank you very much once again for a very interesting and impressive presentation. If anyone has a question, please you can ask questions. I think that there are no questions. Thank you once again, Mr. Kurashvili. Thank you very much.
Thank you. Thank you.
Mr. Namik, as far as I know, Mrs. Mariam Karaishvili has another urgent meeting abroad. Is it possible, Mrs. Karaishvili, to be the next presenter? Mr. Namik, if it's possible, please.
Yes, Tamar Magradze. Please.
Yes, Tamar Magradze is the next presenter, but Mrs. Mariam Karaishvili has urgent problems. She has another meeting abroad, so if it's possible, her to be the next presenter.
Yes, Tamar Magradze.
Thanks a lot for the understanding. First of all, I would like to introduce myself. I am Mariam Karaishvili, obstetrician gynecologist, MD, PhD, associate professor of New Vision University. First of all, I'm welcome to be part of this conference, and many thanks to Mr. Namik and as well board of conference. Now I would like to present my small study, which related to Just 1 minute. Impact of COVID vaccines on menstrual cycles. It will take too much time. Just 5 minutes. Okay, I will start. So first of all, I would like to introduce about what is COVID vaccines and as well how it's affected on the normal menstrual cycle. So COVID-19, as we all know, has recognized crucial to ending the pandemic. Safe and effective COVID-19 vaccines are game-changing tool in the fight against COVID-19 and common side effect of COVID-19 vaccines listed by the EU Medicine of Health Products Regulatory Agency included sore, arm, fever, fatigue, and myalgia, and some studies reported of menstrual changes after receiving the COVID-19 vaccine documented adverse vaccine events. Menstrual changes have been reported after both RNM and inactivated vaccines, and some of short prolonged menstrual cycle rates and early or late onset of menstruation are associated with reduced fertility. According to scientific work and medical literature, the normal rate of menstrual cycle is what the body goes through to get ready for fertilization and pregnancy. Vaccines is one of the greatest success of modern medicine to ending the pandemic. At a time when cases of COVID-19 were on the rise, vaccine hesitance among young women is larger, driven by false claims that COVID-19 vaccines could harm the chance of future pregnancy, failing to thoroughly investigate report of menstrual changes after vaccination is likely to fuel those fears. And if a link between vaccination and menstrual changes is confirmed, this information will allow people to plan for potentially altered cycle. So what about our aim have been to the objectives of this research was to study the effect of COVID-19 vaccine on the late of menstrual cycle. We conducted a retrospective cohort analysis of menstrual cycle data that were collected prospectively. The presenting materials have been taken from New Vision Healthy Hub Center and data collected since September. What about methods? We analyzed data from nearly 69 women age 18 to 43 collected through the fertility apps. Participants agreed to have their data used for research purpose in this particular study, which is small component. We use the age and stages questionnaires. Our initial question was, does COVID-19 vaccines affect their late of menstrual cycle? And we should also as well know that their menstrual cycle rates have been from 25 to 30, and it's a normal time. And most of vaccinated cohort received Pfizer, there have been Sinovac, Sinopharm, as well Moderna. So what about results? We found that women who received COVID-19 vaccine had an average increase in cycle rate of nearly 2 days for each dose. Among women who received the 2-dose vaccine, the first dose was actually with a 2 days increase in cycle rate, and the second dose with a 1 day increase. And after adjustment for age and BMI, the change in cycle rate was still less than 2 days for each dose. And last one, our conclusion, particularly we did not find any abnormality, just slightly changed the menstrual cycle during vaccination, but of course it's not affected on the patient, and of course it's not a permanent problem, just temporary changing menstrual cycle rates. So this have been our conclusion, and this have been our small study about menstrual cycle and COVID-19 vaccine. Thank you.
Thank you very much, Mrs. Mariam, for an interesting presentation. If there are questions, please. I think there are no questions. Thank you very much.
Congratulations, Maya.
Congratulations.
Congratulations. Very interesting. Very interesting. Thank you.
Thanks a lot. Thanks a lot.
Very interesting.
Thank you. Thank you very much. The next presenter, Mrs. Tamar Magradze from Georgia as well. I'm very proud today, to be honest.
Good afternoon. evening.
Good evening. Okay, okay. The floor is yours. Thank you, Mrs. Samad.
Just a minute, I'll share my presentation. Can you see it?
Yes, yes, we can see.
Okay. Good afternoon, dear organizers, dear colleagues, and listeners. It's a great honor for me that I'm with you today. Let me introduce my presentation about the effect of just a minute. Effect of hypertriglyceridemia on diabetic peripheral neuropathy development in patients with type 2 diabetes mellitus in Georgia. Diabetic peripheral neuropathy is one of the major chronic complications of diabetes and the leading high-risk factor of the foot ulcers and amputation. About 60–70% of diabetic patients will eventually develop diabetic peripheral neuropathy. Causes of the diabetic neuropathy are multifactorial, including poor diabetes control, metabolic vascular factors, diabetic duration, and many others. Diabetic neuropathy, around only 3 diabetic patients, they are affected by distal asymmetrical neuropathy, which represents a major health problem. Is it been present with partly excruciating neuropathic pain and responsible for substitutional morbidity and increased mortality. Unfortunately, diabetic peripheral neuropathy often stays undiagnosed. In cross-sectional study of diabetic patients in rural Arkansas, 9.6% had a diabetic peripheral neuropathy diagnosis and 43% of reported symptoms of neuropathy, and 79% with symptoms were not diagnosed. 60–70% of diabetic peripheral neuropathy patients have a diabetic peripheral neuropathy, and 5% of cases painful diabetic neuropathy is registered. Diabetic neuropathy can't be diagnosed only based on patient self-report condition. Patients near the feet to be closely assessed. Up to 15% of diabetic patients have overt neuropathy or at-risk foot. The most presentation of the diabetic polyneuropathy is sensomotor distal symmetrical polyneuropathy, and the prevalence of painful symmetrical neuropathy range from 10 to 26%. One study showed that 20.5% of patients have never reported their symptoms, and 39% never received treatment for this pain. The risk factor of symmetrical peripheral neuropathy to have been extensively studied, and it's clear that apart from poor glycemic control, cardiovascular risk factors play a prominent role. Risk factors for peripheral neuropathy are less well known. Preliminary epidemiological studies suggest that clinical peripheral neuropathy correlates the overweight, obesity, vascular circumference, peripheral arterial disease, and triglyceride levels. The process involving the destruction of the sensory nerve fibers in the foot comments due to excess blood sugar, glucose. Chronic hyperglycemia leads to direct damage of the nerve fibers and the cessation of the axon regeneration. That results of altered sensations and loss of protective sensations that is associated with the increased risk for developing foot ulcers. Sustained and uncontrolled fluctuations in blood sugar levels are the center of diabetic-related complications such as retinopathy, neuropathy, and nephropathy. This relationship was demonstrated in the European diabetes study of installing department diabetic mellitus, whereby diabetic peripheral neuropathy was linked to glycemic control and the duration of disease. Hypertriglyceridemia is a condition in which triglyceride levels are elevated. It's a common disorder in the world. It's often caused or exacerbated by uncontrolled diabetes mellitus, obesity, and secondary habits, all of which are more prevalent in the industrialized societies than its developed nations. The factors that contribute to the elevated serum triglycerides is excess weight or obesity, obesity, physical inactivity, stress, high carbohydrate diets, type 2 diabetes, of course, chronic renal failure, drugs such as estrogens, corticosteroids, retinoids, high dose of the beta adrenergic blockers agents, the certain genetic metabolic disorders, including familial combined hyperlipidemia and familial hypertriglyceridemia. Hypertriglyceridemia denotes high blood levels triglyceride. It has been associated with the atherosclerosis even in the absence of hypercholesterolemia. It can also lead of the pancreatitis in excessive concentration. Our objectives of the study was assess the effect of the hypertriglyceridemia on diabetic peripheral neuropathy in Georgian patients with type 2 diabetes. Methods, there were 19 for type 2 diabetes patients with diabetic peripheral neuropathy, 49 men and 45 women. Compares study group, mean age was more 56, and diabetes duration was 5 to 10 years. All study group patients has hypertriglyceridemia, 50 patients or some age, sex and diabetic duration, but without diabetic peripheral neuropathy, and normal triglyceride were used as a control group as a compare. Methods, we measure the, of course, HbA1c. According to the current guidelines, diabetic peripheral neuropathy was assessed with following battery neuropathy tests. This is monofilament test, tip term temperature tests, vibration tests, and prick tests. You can see the pictures, this tests, and of course neurological examination with a pseudoscan was also performed. This is a non-invasive method for the assessment for the small fiber function from France, and the pseudoscan measures the concentration of the chloric ions produced by sweet gland activity. Sweet gland are innervated by small sympathetic fibers, and pseudomotor sweet dysfunction can be one of the earliest detectable neurophysiological abnormalities is distal small fiber neuropathies. Quantitative assessment of the sweet response has been proposed, an index of the severity of autonomic failure and the early indicator for the regeneration of the small fibers. The American Diabetes Association has identified pseudomotor dysfunction as one of the major clinical manifestations of the diabetic autonomic neuropathy. Assessment of the autonomic dysfunction may identify patients at high risk of the cardiac autonomic neuropathy. This pseudoscan, this method is records the electrochemical skin conductance of the hands and feet generated from the current association with the applied voltage and loss of sweat glands of the loss of their innervations results in the reduced electrochemical skin conductance. And if this is non-invasive procedure, test duration is less than 3 minutes, and no need for fasting, operator independence, easy of the button touch, compact in ergonomic design, quantitative results immediately available, and full clinical results. Pseudoscan provides accurate evaluation of the pseudomotor function of the palm of the hands and soles of their feet, areas with the highest sweat gland density, and measure of the symmetry between right and left side identify the type of peripheral neuropathy. Methods was a result of a battery neuropathy test of a study group were positive, so this can related persons of small fiber neuropathy in control group patients. Neurological tests were negative, while CT scan revealed small fiber damage. Association between hypertriglyceridemia and diabetic peripheral neuropathy was assessed. Study group patients had elevated serum triglyceride levels more than 300. Results according of the data received the diabetic peripheral neuropathy. The study group comprised 65.9%, 62 cases, and triglyceride concentration was significantly higher in type 2 diabetes mellitus with diabetic peripheral neuropathy without the diabetic peripheral neuropathy in normal triglyceride levels. Elevated serum triglyceride were associated with diabetic peripheral neuropathy. And discussion, this study shows that the increased level of serum triglyceride may play important clinical role in the development of diabetic peripheral neuropathy in type 2 diabetic mellitus patients in Georgia. The problems needs further investigation with other important parameters. Thank you for your attention, and I want to assess to my support for the Ukrainian people, our sisters and brothers. I wish them peace and victory. Love Ukraine. Thank you very much.
Thank you very much, Mrs. Tamer. We are also sad about what's going on in Ukraine right now, and our thoughts are in Ukraine with our brothers and sisters in this hard time. Thank you.
Thank you.
If anyone has a question, please. The presentation itself was so all-inclusive and comprehensive that nobody has a question. Thank you very much, Mrs. Tamer.
Thank you.
Thank you. The next presenter, Mrs. Anna Kopalishvili, also from Georgia.
Good afternoon, dear colleague. First of all, I want to share my screen to see my presentation. My presentation is about the impact of weight loss on peripheral neuropathy after bariatric surgery by pseudoscan. I want to talk about what is obesity, obesity causes, complications, what is peripheral neuropathy and causes, peripheral neuropathy risk factors, bariatric surgery for obesity treatment, about our clinical case, and conclusion. What is it, obesity? Obesity is a complex disease involving an excessive amount of body fat. Obesity is not just cosmetic concern. It's a medical problem that increases the risk of other disease and health problems such as heart disease, diabetes, high blood pressure, and certain cancers. Prevalence of obesity in the world. 216 more than 1.9 billion adults aged 8 years and older were overweight. Of this, over 650 million adults were obese. From the 39% of adults aged 18 years and over, were overweight. Overall, about 30% of the world's adult population were obese. The worldwide prevalence of obesity nearly tripled between 975 to 216. Overweight and obesity are now on the rise in low and middle income countries than in high income countries, particularly in urban settings. Overweight and obesity are linked to more deaths worldwide than underweight. How to measure about the obesity is BMI, the screening tool for overweight and obesity, and this is the weight in kilograms. This parameter is weight in kilograms divided by the height in meters and squared. In this slide, you can see which patients have BMI and nutrition status. When we talk about the obesity, it's when the people have 25 BMI and more. Obesity causes is genetics, physical inactivity, high in simple carbohydrates, overeating, frequency of eating, medications, physiological factors, disease, and social issues. Obesity complication is all cause of death is or mortality about high blood pressure, high LDL cholesterol, dyslipidemia, type 2 diabetes, coronary heart disease, stroke, peripheral neuropathy, gallbladder disease, osteoarthritis, and today several COVID-19 symptoms also. Diabetes rate among normal weight, overweight, and obese Americans, you can see by the age, and how you can see the diabetes rate is in obese patients have more than normal weight prevalence. What is it, peripheral neuropathy? Peripheral neuropathy is a result of damage to the nerves located outside of the brain and spinal cord, often causes weakness, numbness, and pain, usually in the hands and feet. It can also affect other areas and body functions, including digestion, urination, and circulation also. Over time, high blood glucose levels and high levels of fat, such as the triglycerides, can damage your nerves. Symptoms depend on which type of diabetic neuropathy you have. Symptoms of peripheral neuropathy. Every nerve in a peripheral system has a specific function, so symptoms depend on the type of nerves affected. Nerves are classified into sensory nerves that receive sensation such as temperature, pain, vibration, and touch from the skin, motor nerves that control muscular movement, and autonomic nerves that control functions such as blood pressure, perspiration, heart rate, digestion, and bladder function also. Diabetic peripheral neuropathy patients with type 1 diabetes for 5 or more years, and all patients with type 2 diabetes should be assessed annually for diabetic polyneuropathy using the medical history and simple clinical tests. These following clinical tests may be used to assess small and large fiber function and protective sensation. Small fiber function, pinprick and temperature sensation. For large fiber function is vibration perception and 10 gram monofilament, and protective sensation is 10 gram monofilament. Bariatric surgery provides an alternative option for weight loss for patients who meet the appropriate medical criteria and for whom diet and exercise have proven ineffective. There is a type of bariatric surgery such as a sleeve gastrectomy, gastric bypass, biliopancreatic diversion with duodenal switch. This is our patient, which is a 51 years old male with type 2 diabetes diagnosed 8 years ago. His weight is very high and BMI is 42. His glycohemoglobin is 10 and 2. High blood pressure. He develops ACE and amlodipine, vitamin D and B12 within its normal range, and patient was on insulin. Neuropathy tests were moderately positive, and pseudoscan is moderate peripheral neuropathy. Diagnosis was type 2 diabetic neuropathy, obesity class 3, and arterial hypertension. Treatment was performed by the sleeve gastrectomy, diet therapy, and multivitamins were performed for these patients. And after 3 months, a patient came with us, and his glycohemoglobin was normal. He lost his weight, and his BMI 33 and 2 kilogram per quadrant. His arterial blood pressure was normal. No symptoms of high blood pressure or hyperglycemia. Neuropathy complications and test scores improved. Battery of neuropathy tests weak positive, and pseudoscan was moderate neuropathy. Vitamin D and B12 and ionistic calcium levels within normal range. Patient was physically active. After 6 months, his parameters was better than 3 months, and the treatment was continued about diet therapy, physical activity, calcium citrate, vitamin D and B12 multivitamins, and the results about the peripheral neuropathy was weak positive and pseudoscan moderate neuropathy. After a year from his bariatric surgery, everything was okay. He don't take any medications, no peripheral neuropathy symptoms, weight loss continued, BNT were near normal, and no neuropathy by pseudoscan also. And for conclusion, I want to see that case study shows positive impact of weight loss on glycemic control, ABP, and peripheral neuropathy. Data of some research indicate positive effect weight loss on diabetic or non-diabetic peripheral neuropathy. Further studies are necessary to prove these findings. Thank you for your attention, dear colleagues. Do you have some questions?
Thank you very much, Mrs. Anna.
Thank you.
I think there are no questions.
Thank you all.
Okay, thank you. The next presenter is Mrs. Guliko Kiliptari. Are you here, Mrs. Guliko? Can you hear us?
No, she's not here because she has birthday today. Maybe.
Okay. So we have to congratulate her then. Very nice.
Next speaker from Kazakhstan, Vibor Singhal.
Yes, sir.
Are you here? Yes, please continue.
Hello, sir. Good evening. Hello, everyone. Good evening to all. So I will share the screen. So this is my research, and it was based on the topic attitude towards COVID-19 vaccination, and it was carried out through a platform survey, and there was a mail ID that was created, and the survey overview was collected along with the number of responses. It was a cross-sectional study between the two countries, mainly the Kazakhstan and the India, and the students of the Al Farabi Kazakh National University situated in Almaty, Kazakhstan, were evaluated through this survey. And first of all, the cross-sectional study. So the cross-sectional study, it refers to the observation of many different individuals. So we assessed all the individuals. First of all, the Indian students studying at Kaznu, Almaty, Kazakhstan, and then the students, Kazakhstan students, the native students of Kazakh, studying in Kaznu University at Almaty. And we then check the attitude towards the COVID-19 vaccination and the hesitancy towards the same. So the responses collected were about 49 responses from Kazakhstan, from the Kazakh students, and 131 Indian students studying at Kazakhstan. So this is the abstract of my research. The recent coronavirus pandemic, which was, as we know, it was associated with increasing human morbidity and mortality, and it mainly impacted the lives of the global population. And due to that, the human behavior and knowledge assessment was also a critical thing during this crisis. And to assess that knowledge and attitude and the perceptions, and also enforce the precautionary measures toward the COVID-19 among the medical students from India and Kazakhstan, I conducted this cross-sectional descriptive study under the supervision of my scientific advisor, Ms. Janna Jalimbetova. And this was a cross-sectional descriptive study which was conducted from 22nd to 30th of July. And the participants were mainly enrolled at different levels of study at Al Farabi Kazakh National University in Almaty, Kazakhstan. And a descriptive analysis was made, including the distribution and the determinants of the 180 students. And in this study, we checked that the vaccine hesitancy, it was posed as a serious challenge for achieving the coverage for population immunity. And due to that, we considered that it is necessary to achieve the high COVID-19 vaccination acceptance rates, and the medical students primarily, they should have a coverage as future healthcare providers. And also the study aimed to explore the level of the COVID-19 vaccine hesitancy and determine the factors and the barriers that may affect the vaccination decision making. Also, the targeted awareness campaigns, regulatory oversight of vaccine trials, and public release of safety and efficacy data, and the trust building activities could further reduce the COVID-19 vaccine hesitancy among the medical students. Then this is showing that we conducted the study between the India and the Kazakh students. The map is showing, and mostly participants were from India, about 73.18%, and a lesser proportion from Kazakh students, that is 26.81%. This is about the response sheet that we conducted through the quiz survey, where the most of the people belong, and they changed, and they belong to the Delhi region, the main capital of India. And considering the responses from the Kazakhstan, the Kazakh students, the main responses were collected from the capital, the previous capital city, Almaty, where the Kaznu is located. Then this is about the faculty which are primarily involved. So all the students, both the Indian and the Kazakh students, were from the faculty of medicine. This is showing what is the proportion of the people according to the year of the study, in the first year, second year, and the third year, and comparing the Indian and the Kazakh students. All of these bar graphs and the data were prepared according to the survey that we had. That was based on the gender, and then the survey questions were analyzed. Each of the survey questions were analyzed, which I'll be describing in my results. So first of all, we checked for about the routes of the transmission in this COVID-19, and then we checked for the various questions that from which source they get to know about this. Similarly, we checked about what kind of thing they use for the study, and what scientific material, what scientific resources they use, and according to the persons, according to the students, the medical students, how many COVID cases were available, how many COVID vaccines were available for the use in their country at the present time when we conducted the research, and their COVID-19 vaccination status, followed by what would they advise to the further persons. And we included all of these questions on a scale of 1 to 5. So how important do you perceive the COVID-19 vaccine to be? And how important you think that the community should get the vaccine? So every question was based on the vaccination history and about the hesitancy that could be seen in the cases, if we concern about the main medical students, and then what do we think about the other students in their surroundings. So these were the primary questions that were being studied. Sorry, just a second. Yes. And also the information about the COVID-19 vaccine, they acquired it from the government or the public healthcare experts. Then we asked about the concerns regarding the COVID-19 vaccine, where the first concern was its safety. Then, is it a good way for the mass vaccination? Getting vaccinated is the best preventive measure or not? Is it the vaccine was tested for enough time or not? About the adverse reactions, about the major thought of the general thought of the students, that if they are against the vaccination, then about the complications that would be developed and an elevated risk to acquire the COVID-19 after getting vaccinated. And do you think that the precautionary measures are better than the COVID-19 vaccine? So these were the major questions that were considered. Then we asked about the hesitation and the unwillingness to take the vaccine, where we checked for the adverse effects. Then we check for about what type of vaccine would you choose. So we based it on the two types. First of all, we checked on the basis of what technology of vaccine manufacturing would you prefer. So we divided into 5 major subclasses, where we asked about non-replicating viral or the protein subunit or the DNA or the RNA or mRNA vaccine or the whole viral inactivated vaccine. So we compared and we prepared the charts for the Indian students as well as the Kazakh students. And then we also evaluated the trust in all of these. Then we prepared the bar graph as follows for all of these. Then we checked for a particular name of the vaccine. So for example, we take the name Covaxin, which is primarily used in India, and also the people of Kazakh really wanted it. So these were the trends that were followed depending on the different types of vaccines that we have. Then we evaluated the trust of Covaxin and the vaccines particularly carried out in the particular country. Like India had the Covaxin, Covishield, and the Sputnik V also as an imported product. And in Kazakhstan, we had Sputnik V, Hayatvax, Kazvak, and the Covax. And then and lastly, we did the comment section, where we checked for the comments and the suggestions from the children on the COVID-19 vaccination and its hesitancy, and why do you think so? And these were the results that were collected. Then we proceeded with the results. Then we proceeded with the results of the survey, where the study included 180 participants, about 131 from India and 49 from Kazakhstan. And it enrolled about all the students from the Faculty of Medicine. And about the Indian students was about, the mean age was about 20.42 years, and the Kazakhstan was 19 years. And the gender prevalence for the Indian students was found to be male 56% and female 44%, while for the Kazakh students, it was found to be male 14% and female 86%. Also, the vaccine hesitancy as we know, it is a limiting step in the global attempts to control the current pandemic with its adverse effects and socio-economic consequences. So understanding the students' attitude upon the COVID-19 vaccine and raising their acceptance is essential in planning an appropriate post-pandemic strategy. So according to the research, the evidence suggests that the importance of concentrating on building trust in COVID-19 vaccines, it includes primarily the use of the trusted messengers to navigate the COVID-19 information. Like most people trust on the news source, some trust on the newspapers, some trust on the social media handles. So these are the trusted messengers that could navigate the COVID-19 information paradigm, and they can also build the confidence in the vaccines by giving the transparency and the expectation management to the people. And also the communities should be engaged early to listen to concerns, answer the questions, and counter misinformation. As public confidence is vaccination is weak, so COVID-19 vaccination programs can only succeed if there is a common belief that the provided vaccines are safe and effective. So some of the vaccination barriers and the beliefs in the present study were false and related to the students' misinformation and genetic effects, acquisition of COVID-19 from the vaccine, and nanochips implantation. And this could be attributed to the lack of information concerning the COVID-19 vaccination in the current curricula. So future inclusion of such topic into medical education would help them to evaluate the risks and benefits of the vaccination. And through this, I derived my final conclusion that the COVID-19 vaccine hesitancy was found in one out of every 10 medical students, primarily as we studied about the Kaznu students from India as well as Kazakh. So it was the common trend that was studied. There was an increased vaccine hesitancy in the students belonging from the origin of the Kazakhstan. And there was noted a lack of awareness regarding the vaccination eligibility, concern regarding the adverse events, and the efficacy of the vaccine, and lack of trust in government. And they were independently predictive of vaccine hesitancy. And heightened risk perception regarding COVID-19 seemed to reduce the vaccine hesitancy also. So as a future healthcare providers, concerns of medical students should be addressed on priority. And students should also be properly guided to proper sources of information during these times. When push comes to shove, so the students should be also equipped with the medical knowledge, proper attitude, and good precautionary measures. So I would like to finally thank all the healthcare workers everywhere who were involved in this COVID-19 pandemic and the vaccination.
Before by Bahud Shukriya. Thank you very much for your presentation.
Thanks to you too, sir.
Dear participants, many participants sent papers and abstracts for publishing. I want just a little bit to speak about our publishing activities. We are publisher. We publish scientific journals in Estonia and Georgia under name, for example, in Estonia, Baltic Scientific Journals, and in Georgia, Southern Caucasus Scientific Journals. Few days ago, we discussed about inclusion all our journals from the as our organization as publisher partner with Web of Science. Just we wait for panel, which they will give to us and for the using, etc. Now, for example, we are under control, under checking of our activity. Our websites already checked by Web of Science, and just wait for the communication pupils who will communicate with them. And if it will be good, I think it should be good. Answer from their organization to be with us as publisher partner. We will send sometimes, for example, special issue to Web of Science. Yes, next As we are publisher also, we publish scientific journals in Georgia, Southern Caucasus scientific journals. We will also send to our publisher partnership suggestion to Web of Science. We will see. Scopus works with universities, and Elsevier, maybe in future we will work also with Elsevier. Just one of university in Azerbaijan discussed with Elsevier about that. We wait answer from university and Elsevier, and we will see how we will include our journals for our publishing activities. Thank you very much for your publishing, for your participation. Yes, Kalbatona, Ekaterina, please continue.
Yeah, Mr. Namik, thank you very much. Have you finished your speech, let's say? Should we continue right now?
Yes, please.
Okay, thank you very much. The next presenters are Nodar Sulashvili, Kahabero Bakidze, Irma Buchukuri, and Nela Grigolea from Georgia, from the Teaching University Millennium. Mr. Sulashvili, are you here? Can you hear us?
No, they're not here. I checked.
I think that they are not here. And the next presenters are also Nodar Sulashvili and Tamara Kropirica. They're missing, unfortunately. So we have to move to the next presenter, Konkulovsky, Danilo, and others. Are you here? There are many co-authors. Can you hear us?
Kalbatoneka,
Yes.
Can you continue presentation about your university?
Yes, of course. Let's Melis Konyulal. Has she presented already?
Yes, she presented.
She has presented already.
Yes,
okay. Thank you very much. I will do a small presentation then about my university. I will not take much time. Share screen, okay. Can you see? You can't see right now, right? Okay.
First, open your presentation. After that, you.
Yes, I'm just trying to open it.
Okay.
You can see the screen, right?
Yes. Okay.
Okay, yes. Thank you very much. So, a few words about the university. I represent the Teaching University Millennium. As I have mentioned already, I'm a research and internationalization coordinator at the Teaching University Millennium, located in Tbilisi, Georgia, Sami Street 35. So it was founded in 2013. It is a higher educational institution that implements undergraduate programs with modern teaching methods to qualify critically minded, competitive, and motivated specialists to meet the needs of the changing local and international labor market of today. Teaching University Millennium offers international students English and Russian language educational programs, which are designed in partnership with employers and respective professionals in various fields, such as pharmacy, dentistry, physical medicine and rehabilitation, business administration, journalism, tourism, international relations, and law, with a special emphasis on medicine direction. About dental simulation and practical laboratory, a few words. It is a multi-profile dental practical laboratory where modern teaching methods are used to generate and develop practical skills. And students on specialized mannequins are introduced directly to all the important aspects of dental services, working with multicultural, multifunctional dental tables and devices, which allows them to develop practical skills in a targeted direction. Simulation Base is a pharmaceutical program where it's possible to demonstrate the application of theoretical knowledge to a practical level. And situational tasks are completed here and clinical biases are selected, which is practically performed by role-playing games. Students establish a pharmaceutical case, which includes medication therapy, which includes delivery of medical supplies, knowledge, the use of pharmaceutical computer programs, etc. And also simulated hospital, which is one of the best multi-profile simulation laboratories in Georgia. It is equipped with modern medical training simulators, multifunctional mannequins, and medical equipment. In the environment closets of the real world, students master practical skills such as patient care, infections, peripheral vein, and other things. You can see some photos taken here. About Oski Hall, equipped with all the mannequins and phantoms needed for the training theme, as well as necessary source, tools, and equipment needed for optical and testing, which are necessary for the live presentation and understanding of process and the images. There are also some photos. Computing with the latest material and technical base, training auditoriums and laboratories, Teaching University Millennium offers an environment equipped with modern technologies for computer cabinets, relevant inventory, free internet incomplete list of infrastructure that our students can use actually. About cafeteria, like other modern spaces of the higher educational institution, Teaching University Millennium, kitchen is always overcrowded. It is a synthesis of traditional and European food, natural and merges with a unique service. And about the conference hall, the conference room is designed for business conferences, actually, seminars, formal meetings, and academic and administrative staff. Also for hosting international and local organizations and implementing joint events. And we have the modern European type academic space that offers university scholarship for high academic achievements, acceptable fee for educational of European standards, flexible schedule tailored to the student, modern and innovative teaching methods, exchange programs with leading universities around the world, and highly qualified academic staff, real employment opportunities, and certificate programs for foreigners. Also, we have the Millennium TV Studio. It's a new television platform that has been introduced at the Faculty of Journalism of the Teaching University Millennium. Students create a variety of multimedia products and master the skills of editing materials. The television is equipped with the latest material and technical base and broadcast in the social media space. Television is focused mainly on establishing democratic values in young people. So on our new campus is located in the central part of Tbilisi, where public transport and other social services are available. We are very much proud of our multicultural community and look forward to students from all over the world. But actually, we are not satisfied with the achievement, and we are looking for new fruitful relationships outside the country for development each students. We strive for development, create an ideal multicultural learning environment, and accept students from all over the world. And we also have the School of International Law. We have the International Center for Politics, Psychological Service for Students, and Turkish and the Indian cabinets, since we are tolerant to other religions, other nationalities. We have the Academy of Education, which aims to provide intellectual support to students with civic responsibilities, etc. If you want to know any further information about our university, you can visit our website, or I can share the information about the university in the chat right now. Thank you very much for your attention. That was all I wanted to say. Thanks a lot.
Thank you very much. Eka, it was a great presentation about your university.
Thank you.
I think we can terminate for today because all the participants just sent to us
Yes.
thesis and yes, and papers. We will publish. Already we prepared conference proceeding book for. We will send to all the participants. We will send to all participants, and it will be about after 1 week. And all the papers which we received also we will publish in our journals from Estonia, and we will send to all authors. Yes. Okay. Any question? Do you have any question?
Congratulations.
Thank you.
Congratulations, my friend Nazik. All the best, Ekaterina. All the best. Congratulations, my congratulations. Thank you very much for the invitation. Thank you. You're welcome.
Just
thank you, Mr. Ramas. Thank you very much.
One request from participants: write your full name on the chat section, because on the certification we'll need exactly name and surname. Уважаемые участники, одна просьба: напишите ваше полное имя на чате, чтобы так можно, во время сертификации, чтобы мы могли взять полное имя только через чат нашей конференции. Спасибо огромное. Thank you very much. Just I will wait a little bit for all the participants.
Çok sağ olun Haluk Bey. Çok minnettarım. Çok yaptınız.
Buyurun. Yes, it's good. Thank you very much, Kovataneka, for
thank you.
moderation, for as moderator. Maybe we will think for the next conference with the university. It will be
of course.
Medical and as your specialization, right?
Yes.
Political, right?
Yes, of course.
Yes, we will think. We will discuss about.
Thank you very much. Thank you.
Conference. And I wait anyway answer from your web science. Maybe we will discuss also with you about operation on publishing section. Okay. Yes.
Okay. Have a nice evening. evening or
Thank you very
bye,
much.
Thomas.
Very much. Okay. Bye-bye. Take
Thank you.
care.
Thank you.
Bye-bye. Bye-bye.
Bye-bye. Thank you.
Zemine Hanım, kudafız. Zemine Hanım.
Namik müəllim, çox sağ olun, çox təşəkkürlər. Yenə həmişəki kimi möhtəşəm bir konfrans. Təşəkkür edirik. Spasibo, Svetlan.
Nəyi bacarıq? Bizim avtorlardan xahiş edirəm ki, daha doğrusu iştirakçılardan xahiş edirəm ki, tam adlarını yazsınlar.
Bunu da söyleyeyim.
Aferin. Katerina bak.
Çox yaxşı idi hər şey. Bizdə o, belə deyək, proqramın o məhdudiyyəti, yəni proqramda problemlər yaranmaması üçün həkimlərimizdən bəziləri deyəsən girməmişlər, amma sabahki gün üçün inşallah hamı burada olacaq. Yəni, çox təşəkkür edirik Namik müəllim. Yaxşı ki, varsınız.
Oldu. Çox sağ olun.
Sağ olun, təşəkkürlər.
Çok sağ olun, sağ olun.
Oldu.
Sağ olun, doktor, sağ olun.
Sağ olun. Sabaha kadar.